Now, guys, today we are going to talk about splenectomy, and it's an interesting and an intriguing topic. And again, I will start with the indications. I will not go into the details because all of you are postgraduate students, and naturally you know what are the indications. Just to brush up the main indications, it would be number one, I would remember it at congenital, traumatic, inflammatory, neoplastic, and miscellaneous. And all of you know that congenital spherocytosis, or you can call them as part, and there are certain diseases, particularly glycogen storage disorders, in which you might have to go for a splenectomy. Then trauma possibly remains a very common indication, and all of you who are working as surgery resident must have been encountering traumatic splenectomy. Inflammatory, most of the circumstances, it is due to splenic abscess or due to parasitic cysts, and quite unnaturally you can get some rare infections in which you can have to do a splenectomy. Neoplastic is usually, a splenic neoplasm is quite uncommon, but having said that, it becomes part of other neoplastic conditions, particularly cystic neoplasms of pancreas, where you might have to do a splenectomy along with distal pancreatectomy, with a D3 gastrectomy at times, and such other procedures. Or if you have a primary neoplasm of the spleen, which is, as I said, is very rare. We used to do a large number of exploratory laparotomy for lymphomas, but that has become a rarity nowadays, thanks to as you get the PET CT scans, which would be able to delineate what is the affection. But in good old days, maybe around a decade or so back, we used to do laparotomies and do splenectomy as part of a procedure for lymphomas. Miscellaneous mostly comprises of hemoglobinopathies, and that is one of the major indications for splenectomy in this part of the world. And during your exam, this is a very important issue, and I'm going to discuss this in detail today. We have to talk of chronic ITPs, which are very important, and again there are certain small tips to be followed while you are dealing with chronic ITPs. And finally, you have other conditions like spherocytosis, etc., where you can do it's an extension of the hemoglobinopathies to as such. And once in a while, you have to do it as part of portal hypertension, particularly when it involves the splitting or the portal vein thrombosis, exclusively on the left side. And at times, as part of a shunt procedure, a splenorenal shunt procedure in non-cirrhotic, a cirrhotic portal hypertension, you might have to, as an adjunct, you might have to do a splenectomy. So by and large, these are the major reasons why one would go for a splenectomy. Now, coming to the steps of the procedure. Now, during the exam, you are going to take up the sheet which shows a splenectomy. Now, remember, splenectomy has got two approaches. This is something which you must first keep in your mind. Now, one is the one that deals with in the emergency, which is called a traumatic splenectomy. The other is an elective splenectomy, which we do in the elective setting. While you are doing a traumatic splenectomy, This is called dual pedicle approach. Dual pedicle approach means most of you, if you have seen a traumatic splenectomy, I mean there is a trauma and you have done laparotomy, you find that the spleen is shattered, it's a grade 4 injury of the spleen and it has involved the pedicles, it has bled and it has now been sealed and you are going to do the splenectomy. Most of the circumstances you will find almost part of the splenectomy has been done. You are just completing the splenectomy. So here, the question of dissecting the gastrosplenic ligament, the lienorenal ligament, which are the two main pedicles of the spleen, doesn't come. You basically know that this is the spleen, and the spleen is shattered here, and this is the pancreas somewhere here. This is the gastrosplenic which is torn, and the splenic artery possibly is torn. You just put in a clamp like this and cut in between and you take out the spleen. It's more of an excision of the spleen. So as you are approaching both the gastrosplenic ligament and the lienorenal ligament together, we call this a dual pedicle approach at the same time. So it's a double pedicle approach. You basically clamp it and you secure the ligatures and come out, and you are going to take care of all the vessels by just putting in 2 clamps or putting 2 ligatures, and it's all over. But this is the commonest part from splenectomy, but that does not mean that is the ideal technique for doing a splenectomy. The ideal technique of doing a splenectomy is when you are dealing with, say, a thalassemia. And you know, in thalassemia, once the patients are transfusion dependent, again during the exams you may be asked what would be the indication for splenectomy in a patient of thalassemia. Now in this part of India, I mean the commonest thalassemia that we encounter is called an E-beta thalassemia, which is completely different from something called a beta thalassemia. Now keep it in mind, E-beta thalassemia and beta thalassemia are 2 different types of thalassemias. Beta thalassemias are more common in the western part, in some parts of India as well. Beta thalassemia, as you know, would present for splenectomy in the pediatric age group, that's less than 5 years of the age, that will have a rapid progression. But E-beta thalassemia is not a subtype of beta thalassemia. E-beta thalassemia is one, just remember, it is an E-thalassemia where the behavior changes to beta thalassemia, and these patients usually present in the sometimes in the late teens or in the first decade of between 20 to 30 years of age, or between 15 to 20 years of age. And quite often, most of the residents mistake it, that they start thinking that this is nothing but a beta thalassemia. But beta thalassemia classically will not present so late. So it is actually an E-beta thalassemia, which is an E-thalassemia, and clinically start behaving suddenly as an E-beta thalassemia, a beta thalassemia, and therefore the nomenclature. The indication for these is, number 1 is transfusion dependence. So what we mean by transfusion dependency, that means the patient requires at least 1 to 2 transfusions per week. So if the transfusion requirements goes to more than 4 transfusions per month, that is an indication that the patient is heavily dependent on transfusion and one should opt for splenectomy. Number 2, you find that there is a growth retardation. And why this growth retardation occurs? Because the spleen is so huge that it is pushing the stomach up, and therefore there is early satiety, the patient is unable to take food, and in the early adolescent age group, So therefore, they are unable to take much food and the nutrition is depleted. So there is failure to growth, and that is also an indication for doing an early splenectomy in this patient. Number 3, it's a rare blood group. Now you find that these patients have got very rare blood group, and then naturally it's a negative blood. You cannot go on replenishing negative blood, so you buy time by doing a splenectomy. Number 4, you are afraid that this patient is having, due to repeated blood transfusion, either heart failure, and these heart failures are mostly due to huge amount of iron overload, as a result of which there is iron deposition in the heart, and therefore they are prone to development of heart failure. Now, if these circumstances arise, then you temporarily buy time by splenectomy, which is going to reduce the transfusion requirement, at least for the time being, until you prepare the patient for a definitive bone marrow transplant. So coming to the steps, how you are going to do this. Now, before we do this, let us just revise let us just revise how we are going to look at the anatomy. Number 1. Now look at this, the anatomy. Now, this is the spleen. And you know this is the pancreas. The pancreas in there. Some of the people would give it a name called a rare type of ligament, which they call a pancreatico-splenic ligament, which I doubt. It's just a few folds which you can dissect out. But some people have given them a name called pancreatico-splenic ligament. Okay. Now you find here the splenic artery going in the top on the superior aspect of the pancreas. You will find the splenic vein going behind the pancreas. And you will find the splenic artery then turns here to give the branch up as the short gastric vessels, and forms the overlying blanket of gastrosplenic ligament, as the stomach is situated somewhere here. Here I am drawing it quite far off, but it is actually very close. And if you look from above, what happens that if this is the stomach and this is the spleen, so the gastrosplenic ligament would go like this, and here you will have the short gastric vessels passing like this, and you know this is going to go over the pancreas, and this is going to go behind and get attached over the kidneys. So this is the spleen, this is the stomach, and this is the pancreas. The splenic vein is going to enter like this, The splenic artery is going to enter like this, and this forms the lienorenal ligament. This forms the gastrosplenic ligament. As I said, some people would give this a nomenclature as we call a pancreaticosplenic ligament, and at times there is an attachment with the diaphragm, and they call it lienophrenic ligament. So once you know the anatomy very clearly, you are going to proceed with the steps. The steps comprises of number 1, the incision. So patient lies supine on the OT table, general anesthesia with endotracheal intubation, antiseptic wrapping and dressing. If you are in the emergency room, you are going to give a midline incision for sure. Now, if you are doing an elective procedure, you are going to give mostly a subcostal incision. There are certain exceptions to this. The exception number 1 is if you are dealing with a chronic ITP. In that case, choose to give a midline incision, because if it is a patient of chronic ITP and if you cut and incise the muscle, there will be a lot of ooze. So in those circumstances, we prefer to give a midline incision. Number 2, if you choose to give a splenic graft, then you can choose to give a paramedian incision. For this, you give a midline incision, or else you choose to make a left subcostal incision. The abdomen is opened and you choose and proceed for splenectomy. Now, as you proceed for splenectomy, step 1, you remember, is the delivery of the spleen. This is the key word. If you have not delivered the spleen, it is impossible to do a splenectomy. Now, the delivery of the spleen is very easy in the lower pole, because the lower pole is usually free. But the upper pole, you will find, is attached to the the diaphragm, and the upper pole and the mid portion is very closely related with the stomach. So you need to sever the splenophrenic ligament. So the upper pole becomes free. Then you sever at least 1 or 2 short gastric vessels. And once you do so, what happens is that this portion is freed, this portion is freed. And once it is free, the upper pole can be delivered. So the tricks to delivery of the spleen not lies in the lower pole, because the lower pole is very easily deliverable. It's very easy. You just simply put your fingers here and you can deliver the lower pole. But if you try to deliver the upper pole, you will have resistance in terms of phreniosplenic ligament, and you will have resistance in terms of the upper branches of the short gastric vessels. And believe me, the stomach and the spleen is almost in direct contact, and it's very close. And unless you're very careful, you might end up in injuring part of the stomach here. So once you have severed these two, the upper pole can be delivered into the wound. So step 3 is spleen delivered into the wound. So what happens is that the spleen is out of the abdomen, and the spleen is at present hanging with the short gastric vessels, and behind, of course, with the splenic artery and the vein, and it is attached medially with the kidney by the lienorenal ligament. Now, at this stage, there are two ways of approaching. Number one, you just sever the short gastric vessels. And once you have severed the short gastric vessels, you are sure that you have the splenic vein is here, and you know the splenic artery is here. And of course, the pancreas will be in front of it. There are a group of people who at this stage would make an incision in the lienorenal ligament. And as you put your dissection behind, the whole spleen is going to come out. So the incision is on the lienorenal ligament. This is one part. And number two, as I said, the gastrosplenic ligament with the short gastric vessels are ligated and divided. So once you do this, you come to the step 4. And the step 4 comprises of the pedicle. Now, once you have done this, and you have done this, the spleen is hanging, being attached only with the splenic artery and the vein. Now, at this point of time, try to understand that there are certain variations. We tend to believe that in most of the circumstances, the splenic artery would go like this. But in certain circumstances, it might branch like this outside, and you might have polar branches going like this. And it is almost an inch or before it goes into the spleen, you might have polar branches. You might also have the same with the vein. So what you need to do at this point of time is gently dissect the splenic artery first. And why the splenic artery first is because the pancreas is situated, and you know the spleen is here, and the splenic artery is in a very constant position in the upper end of the pancreas. So you can dissect it here very thoroughly, and you can ligate it here and divide it in the under vision. So once you have done this, suddenly you will see that the blood from the spleen is coming back because the vein is open, the artery is ligated. So once you do this, now the spleen is draining only with the splenic vein like this. So comes the step 4 or the step 5. In the step 5, you dissect very carefully the pancreas, then in the splenic hilum. So the pancreas is protected. And once the pancreas is protected, in the step 6, you will find only the spleen hanging with the vein passing like this. And therefore, you will ligate this and take the spleen out. So if I revise the steps once again, in the elective setting, it is left subcostal incision. However, in patients of chronic ITP, but the patient is bleeding, we will choose to make a midline incision. In certain cases where we choose to give a splenic graft, we might use a paramedian incision. Step 2 is after you have explored the abdomen and you are going to try to deliver the spleen into the main wound outside the abdomen. The main hindrance will lie with the linophrenic ligament, I mean the splenophrenic ligament, which is situated somewhere here. You are going to sever the number 2, the first few branches, which are the short gastric vessels. They are ligated and divided, and once you do so, the lower pole as such is a free pole, so it can be delivered out. The upper pole is delivered outside the main wound. So you go to step 3, the spleen is delivered outside the wound. At this point of time, you are going to take 2 steps. Number 1, the gastrosplenic ligament with the short gastric vessels are ligated and divided, so the spleen becomes free from that of the stomach. The linorenal, the spleen is folded up like this, and you make an incision in the lateral edge and enter into the plane between the spleen and the kidney, which is the linorenal ligament. A go behind, and the whole spleen is now going to hang with 3 things: the splenic artery, the splenic vein, and the pancreas. As I said, in most circumstances, the vessels goes very close into the splenic hilum and then divide. But once in a while, they can divide an inch or so before it enters into the hilum. So you have to ligate the main branch. The safest part is to ligate it at the upper border of the pancreas, dissect the splenic artery and ligate it there. The step 5 is dissect carefully the pancreatic tail from the splenic hilum. And once you do this, the only thing that remains is the splenic vein. You ligate the splenic vein and close the abdomen. Now, there is a question that is asked quite often: are you going to put in a drain? The answer to the question is no drain. So you are normally not expected to put in a drain unless you have specific reasons about injury to the lesser curvature, greater curvature of the stomach, or to the tail of the pancreas. You are very uncertain, or else it is not a customary practice to put in a drain, and the abdomen is closed in layer. Now, if we now once again try to understand what are the variations. Now, variation number 1 is when you are dealing with patients who have portal hypertension. Number 1. Number 2, in patients who have repeated splenic infarct. Now, these are special circumstances, of which the one that I uttered first, the portal vein, the portal hypertension, is particularly special. Now, why it is special? It is special because of the fact that normally, if most of you have seen splenectomy in an emergency, you will understand it's a pretty easy job. And in the emergency, I call them excision of spleen under GA. But the challenge comes when you are doing an elective splenectomy. Now, in portal hypertension, what happens is that there is development of the portocaval anastomosis opens up. So, this is the diaphragm, and this is the portal system. So there is large number of blood vessels which develop with the splenic system, which is the portal system, and the azygos system. So there are large number of vessels which will be there on the lateral aspect of the spleen. And therefore, if you try to just put your fingers in here and try to deliver the spleen, believe me, the bleeding is going to be tremendous, and it is impossible to control the bleeding. So when you are dealing with a patient with portal hypertension, you must be careful that this patient will have an extra area to deal with That's the porta cavernous anastomosis or the porta splenic vein with the azygos system, which is going to play a major role in terms of bleeding. The second is if you have a splenic infarct, the same thing happens. I mean, because of the infarct, there is large number of adhesion which develops with the diaphragm. And in these circumstances also, most of the people unknowingly put their fingers into this and it bleeds horribly. And even after you take out the spleen, you'll continue to see large number of bleeding, oozing coming out from the diaphragm. It is very difficult to control this bleeding. So you need to remember that this is variation number one that you keep in mind. The second point, as I said, is the variation number two is when you are dealing with hereditary spherocytosis. Not a single splenenculi can be kept. Now the question comes in traditionally in hemoglobinopathies or thalassemias, you tend to take out the splenunculis, but there are reasons to believe it doesn't really have much role to play. But yes, traditionally you should be looking at the splenunculis and take them out. The variation number three is when you are dealing with chronic ITP. Now, the indication of splenectomy in chronic ITP is when you have used steroids, and in certain circumstances you have used immunoglobulins and still the patient continues to bleed. These are steroid dependent patients. So in them, you have to be very careful that these patients are on steroid dependence, and therefore all the measures related to steroid dependency has to be taken care of. But very importantly, as I said, the incision in this patient, always try to make it midline. Because if you open up the muscles, they bleed horribly from muscles. And even in certain cases, if the splenectomy fails, you are going to have a large number of muscle hematomas. So these are the three variations in technique that you should remember. One, which you are dealing with portal hypertension and splenic infarct, about the neovascularization that takes place with the diaphragm. Variation number two is related with splenunculi, traditionally with spherocytosis, but yes, in spherocytosis absolute, traditionally with thalassemias as well. And variation number three is when you are dealing with chronic ITP. You have to be very careful in dealing with the muscles, and even in certain adults too, because the bleeding can start from that area as well. Now coming to the next important issue is splenic preservation. Now at postgraduate level, this is a very important issue. Now splenic preservation, of course, the traditional one is total splenectomy. Then you start doing a splenic preservation, which is called polar splenectomy or partial splenectomy. Now, what you do in partial splenectomy is you have the spleen like this. You know that the artery will pass like this, and it is going to give a branch like this. The rest of the branches like this. You also know that the vein is going to pass like this, with the branches coming from here, the branches coming from here, the branches coming from here. So what you are going to do is you are going to preserve, remove these vessels, remove these vessels, remove these vessels, and you can remove these vessels. So you keep these branches intact. Now once you keep these branches intact, a line of demarcation is going to appear. a line of demarcation appears. So once the line of demarcation appears, so you are going to remove the rest of the spleen and keep the upper pole of the spleen intact. Now, what you need to understand is that now this is the spleen. You are going to have a raw area here. So this raw area can be covered by two. Number one, you can usually keep the splenic capsule, the capsule that you have with the spleen. You can keep it and just wrap it up with the splenic capsule. Okay. Alternatively, what you can do is you can put in a vicryl mesh here. So the raw area in the spleen is gone and it continues to get supply from the artery and the vein. So this is a splenectomy, which is known as a partial splenectomy. You can achieve it with the help of a radiologist as well, and you can actually ablate rest of the branches and keeping a single polar artery with the main artery, and you can preserve the spleen. The third technique is splenic graft. Now there are two different techniques of splenic grafting. One technique is called the slice graft. The other is called an omental wrap. What is done in a slice graft is you get the spleen, you cut the spleen and take a small slice of the spleen, just like a small slice. And what you do is, now this is the abdomen, abdominal wall. This is the muscle. And this is the abdomen here. So this is the parietal peritoneum. You make a nick in the parietal peritoneum. The way you do an incisional hernia operation, create a space in the preperitoneal space. You can insert the slice graft inside and then like it and make few ties so that it is hidden off from the rest of the abdominal cavity. The second one is you can take an omentum, and within the omentum you can put in a part of the spleen and ligate it. And so these techniques are known as splenic graft techniques, which comprises the splenic slice graft or the omental wrap. So basically, as I said, we can divide it into total splenectomy, then we have partial splenectomy with wrap with the splenic capsule, or the, as I said, with the vicryl mesh, and a splenic graft which comprises of these two techniques. Now the question comes, what about the physiology of splenic preservation? Now total splenectomy, the immune function is gone. And therefore, a vaccine is a must. The pneumococcal and these vaccines becomes mandatory. Now, when should the vaccine be given? Now, remember, it should be given at least 72 hours before surgery or 10 days after surgery. The second is you go for a partial splenectomy. It has got the advantage that the splenic blood circulation remains intact, and therefore oxygenation function and immunoglobulin function and the T cell functions remains intact. So here, immune suppression is 0. The third is a splenic graft. So as I said, there are two ways. Number one is the immune function, and the second is opsonization. Now, opsonization depends on the intrinsic circulation of the spleen. So if you give a graft, this function can go down. Though there are evidences to understand that it develops after some time, but the immune function regains after 6 weeks. So the best would be the partial splenectomy. The second best will be a splenic graft. The third best, of course, the worst would be a total splenectomy. Now coming to finally the complications of splenectomy. Now, as you are asked during the exam, you are going to answer for...
Sir, can you repeat about vaccinations again?
Okay. As I said, in vaccination, the issue is you have to give it 72 hours before the planned splenectomy or 10 days after the splenectomy is over. In between the 3 days and 10 days, there is a general immune suppression, and therefore a vaccination is not indicated or should be avoided. Clear?
And so for splenic graft, please.
Splenic graft. Okay, as I said, splenic graft.
Yes, sir.
Splenic graft is a technique where you can take a slice of the spleen, and you can make a pocket in the parietal peritoneum, create the pocket, and insert the splenic graft inside and close it with interrupted bites like this. Or you can take a small part of the spleen and wrap it up with an omentum and close it. As I said, in splenic graft, opsonization function is not going to be there because the intrinsic circulation, portal circulation from splenic circulation is lost. But as I said, the immune function of the spleen, that is production of the T cells and the immunoglobulin, is retained. However, there is an initial period of lag, which is called a phase of hibernation in the first 6 weeks. After that, the immune function comes back. So,
Okay, sir.
So you should either vaccinate them, or if you are not vaccinating them, you must give 6 weeks of amoxiclav as a prophylaxis to these patients. Clear?
Okay, sir. Yes, yes, sir.
Okay.
Thank you, sir.
Coming finally to splenectomy and its complications. Now, splenectomy, well, as you are going to say, for any operation under general anesthesia, shock, sepsis, and hemorrhage, the complications specific to splenectomy are: number one, the anatomical complications. Of course, the worst nightmare would be ligature slippage. Either the splenic artery or the vein. This is really bad. I mean, by the time you come, the patient is exsanguinated. The second is, as I said, though theoretically the spleen and the stomach is wide apart in books of anatomy, but in real life, they are extremely close. And while you are trying to basically isolate the short gastric vessels, you can actually lead to an injury to the greater curvature, and therefore there must be a gastric curvature injury. In some cases, as because the stomach has been under compression of the spleen and there is extensive devascularization of the stomach, in certain cases they can go to gastric dilatation.
Sir, is it mandatory to cut the gastrocolic omentum before doing this procedure? Ligation of the gastrocolic omentum to enter into the lesser sac. Is it mandatory to...
Gastrosplenic is good enough. You don't need to cut the gastrocolic omentum. Okay. If you deliver the spleen outside, the whole anatomy becomes clear. The problem is most of us try to dodge the spleen, keeping it inside, and it's end up after some time you lose control, start bleeding, and then you put your clamp from here and there. That becomes an excision of spleen. So if you want to really do a splenectomy, the upper pole has to be mobilized, the lower pole has to be mobilized, the whole thing has to be delivered into the womb. Then you gently go on dissecting the gastrosplenic ligament, open up the lineal ligament, you get the artery and the vein and the pancreas, you dissect it out and the whole matter is over. Clear?
Okay, sir. That means there is not necessary to enter into the lesser sac.
If you are cutting the gastrocolic, I mean the gastrosplenic ligament, you are entering into the lesser sac.
Okay, sir.
Okay, in the lower part, it becomes the gastrocolic. In the upper part, the same thing continues as the gastrosplenic. Clear?
Okay, sir.
The fourth one is injury to tail of pancreas. And as I said, there can be a pancreatic fistula. And you must know how to deal with a pancreatic fistula if it so arises. The far more interesting complications are the physiological complications. The most important physiological complication, of course, in the exam, the most important one is OPSS, or overwhelming post-splenectomy sepsis. They used to call it OPSI, overwhelming post-splenectomy infection. Now they call it OPSS. Now, from the exam point of view, this is the mostly spoken complication, but believe me, it is an extremely rare complication. OPSS, the incidence is highest at age less than 5 years, where the incidence is 2%. If you are dealing with a patient with a chronic hemoglobinopathy, then the incidence can be between 7 to 10%. In adults, it's a query. Once in a while, you might have an OPSS in an adult, but OPSS is specifically a complication of the younger age group, less than 5 years, and mostly in patients who are patients of hemoglobinopathy. They have an immune suppression and therefore they can have this. The second is thrombocytosis. Now, this is a complication which most of you have missed. I mean, if you do a platelet count, what happens in a chronic ITP patients, if you clamp the splenic vein and if you do a count, within 30 minutes, the count shoots up. And I have had a large number of patients where the count have gone up to 10, 11 lakh by third to fourth day. So it can go up very hugely. And in some cases, though of course I have not seen, but thrombocytosis is usually an asymptomatic phenomenon. But if you do encounter that, then you might have to give the patient DVT prophylaxis, and quite often we discharge the patient with ecospirin so that it acts as an antiplatelet agent. The other complications that can happen is mostly specific to the particular disease. That means when you are dealing with a portal hypertension, you can have extra bleeding, as I said, because of the vessels that starts bleeding from the diaphragm wall. In a case of spherocytosis, if you leave behind the spleneum, these patients can develop a recurrence. And of course, the MCQ question that always comes is lower left lobe atelectasis. That is the MCQ question that you all know, but at postgraduate level, that's pretty normal for patients to have that, because you need to take care of the pain and the physiotherapy, or else all patients will have a lower left lobe atelectasis. But by and large, you should be discussing about the anatomical and the physiological complications. So that brings us end of the class. So if there is any question related to, as I said, the steps, the anatomy.
Sir, how emergency splenectomy differs from the elective splenectomy? What initially you have told the two clamp method? What is that?
As I said, now what happens is, now look at this. Now suppose this is torn, or if I draw a diagram once again. So this is torn. This is the artery, partially torn, it is bleeding, the vein torn. In most of the circumstances, you will find the epiploic vessels also torn. So the whole thing is just lying there. So you just need to put in the clamp here, and the spleen has to be delivered out. So you cannot distinguish between the gastrosplenic ligament and the lienorenal ligament. The spleen is already shattered, lying there at the state of auto-transplantation or auto-amputation. You just need to put your clamp and secure the vessel and come out. And very frequently, if you are doing it inadvertently, you can end up injuring the tail of the pancreas. Whereas in an elective splenectomy, as I said, your approach is very careful. You first approach the upper pole, delivery, gastrosplenic ligament, lienorenal ligament, then you go for the splenic pedicles, pancreatic tail, and that is how sequentially you go on doing the splenectomy. But in emergency, you just put in 2 clamps and try to negotiate the splenic pedicle at the same time and excise the spleen out.
Okay, sir.
Sir, I have one question, sir.
Yeah.
Sir, you were telling about the incisions. Sir, in case of a splenic graft, sir, what is the reason for putting the paramedian incision?
Oh, yes. And now, if what we tend to do in a splenic graft is we would place it in the parietes like this. Get my point? So it is underneath. So if I make an incision like this, it is very difficult to create a pocket from above and put in the graft here.
Okay.
But in a paramedian incision, you can hold it up, create the pocket, put in the graft, and once again resuture the parietal peritoneum.
Sir, is it like the tape plane which we used to do
surgery? Exactly, the tape plane.
Sir, one last question, sir. Sir, you were telling about the splenic graft, sir, physiology of splenic preservation. Sir, the properties of immune function is still intact, but the opsonization is gone, sir.
Yeah.
Then in that case, what to see about this, sir? Because of the opsonization, there may be increase in the capsulated bacterial infection. So to prevent that, necessary
that's the reason. Yeah.
Sir, is it necessary to give pneumococcal vaccine or what in splenic graft?
I won't go into the details, but I would suggest for your exam, your answer should be yes. Okay?
Okay.
For exam, the answer is yes. Practically, we have got the world's one of the largest series where we found that it's not required. But for your exam purpose, your answer should be